Welcome to the Deep Dive. We're here to help you cut through the noise and get straight to the essential information you need for revision.
Exactly. We do the digging, you get the high-yield knowledge.
And today, our focus is multiple myeloma. We've got some solid revision notes here.
Yep, and our mission is to break it all down, definition, causes, symptoms, treatment, the whole lot, into something clear and memorable.
We'll cover it all, aiming for a really efficient overview. We'll even drop in some memory aids. Sound good? Okay, let's unpack this.
Right. So first off, what is multiple myeloma? Fundamentally, it's a type of cancer.
A blood cancer, specifically.
Yes, a cancer of plasma cells. Now, plasma cells, you'll remember, are a kind of white blood cell, and they live in the bone marrow, that spongy stuff inside bones.
And in myeloma, these plasma cells go wrong somehow.
They do. They become abnormal, malignant, and start multiplying way too much. They basically take over the bone marrow.
Okay, so they're crowding out the normal blood-producing cells?
Precisely. And this leads to a few key things. You get this massive overgrowth of abnormal plasma cells in the marrow.
Which can damage the bone itself, right?
Absolutely. Bone destruction is a major feature. And these cells also pump out huge amounts of an abnormal antibody.
Uh-huh. The monoclonal protein or paraprotein?
That's the one. You find it in the blood serum or sometimes in the urine. It's a big clue.
So the main characteristics are these malignant plasma cells taking over bone damage. We call those osteolytic lesions, don't we?
Yes, like little holes in the bone. Plus, kidney problems often crop up, and the immune system gets weakened because the normal antibody production is disrupted.
It's classed as a hematological malignancy then, originating in the blood system.
Correct. And we could even subclassify it based on which type of monoclonal antibody is being overproduced. IgG myeloma is the most common type.
And it doesn't just appear out of nowhere, does it? There's often a lead-up.
That's a really important point. Often it develops from an earlier stage called MGUS.
MGUS, monoclonal gammopathy of undetermined significance.
Exactly. It's a pre-malignant state. You have the abnormal protein, but none of the myeloma symptoms are organ damage. It's usually asymptomatic.
But it can turn into myeloma.
Yes, there's about a 1% risk per year of it progressing, so it needs monitoring. Think of it as a warning sign, maybe.
Okay. And then there's smoldering myeloma.
Right, that's sort of an intermediate stage between MGUS and active symptomatic myeloma. Higher levels of the protein or more plasma cells in the marrow than MGUS, but still no actual organ damage.
So the risk of progression is higher there.
Generally, yes, but it varies. Some people can stay in the smoldering phase for a long time.
Got it. So it's a spectrum. What else defines myeloma generally? Age, gender.
Yeah, it's quite rare in people under 40. The average age of diagnosis is, over 60, often around 70 or so.
Okay.
And it tends to be slightly more common in men and also more common in individuals of Black African or African Caribbean ethnicity.
And these monoclonal antibodies the myeloma cells produce, they don't actually work properly, do they?
No, they're non-functional usually. And you can often find bits of them, called Bence-Jones proteins, in the urine. It's all part of this group of conditions called plasma cell dyscrasias.
Right, so that sets the scene. Now, what about the why? The etiology. You said the exact cause isn't known.
Correct. We don't know the precise trigger, but we know it fundamentally involves these neoplastic, abnormally growing plasma cells in the bone marrow.
And MGUS is often the starting point.
Very often, yes. It seems like certain genetic changes happen as B lymphocytes, the cells that become plasma cells, are developing.
What kind of genetic changes?
Things like chromosomal translocations, bits of chromosomes swapping places, or trisomies, having an extra copy of a chromosome. These can mess up the cell's growth instructions.
And mutations, too. I see RAS genes mentioned.
Yes, mutations in genes like RAS, which normally act like brakes on cell growth, can contribute to the uncontrolled multiplication.
And how does this link to the bone problems? That seems so central to myeloma.
It is. The myeloma cells basically disrupt the normal bone turnover process. You have cells that break down bone, osteoclasts, and cells that build it up, osteoblasts.
Okay.
The myeloma cells release factors that ramp up the osteoclasts, the bone breakers, and suppress the osteoblasts, the bone builders.
Ah, so it's an imbalance, more breakdown, less building.
Exactly. That leads to the osteolysis, the bone weakening, those lytic lesions, and as bone breaks down, calcium gets released into the blood.
Leading to hypercalcaemia. Got it. And the kidneys, how do they get damaged?
That's often down to those monoclonal free light chains, the smaller parts of the abnormal antibodies.
The Bence-Jones proteins?
Yes. They're small enough to get filtered by the kidneys, but when there are loads of them, they can overwhelm the system, they can block the kidney tubules, cause inflammation. leading to renal dysfunction.
Wow. Okay. So it's a complex mix of genetic hits and the consequences of these abnormal cells and proteins. Let's talk risk factors. We mentioned age, male sex, African Caribbean descent. What else?
A family history is relevant. Having a close relative with myeloma increases risk slightly.
Suggesting a genetic element, perhaps?
Possibly. Then there are environmental factors, exposure to radiation, certain chemicals like benzene, maybe pesticides. The evidence is suggestive for some of these.
Anything else?
Obesity seems to be linked as well, and specific underlying genetic abnormalities, though those are often found once myeloma develops rather than being a known prior risk factor for most people.
Okay, so a mix of non-modifiable factors like age and genetics, and potentially some environmental or lifestyle links. Now, pathophysiology, boiling it down, how does myeloma cause problems?
At its core, you have malignant plasma cells multiplying out of control in the bone marrow.
Check.
These cells produce huge amounts of one specific type of abnormal protein, the monoclonal protein or M protein.
Right, and these M proteins and the cells themselves cause the trouble.
Exactly. The sheer number of cells crowds the marrow, interfering with normal blood cell production. That's where the anemia comes from, not enough red blood cells.
Makes sense.
The M proteins themselves can directly damage organs, especially the kidneys, as we discussed. And the myeloma cells also suppress the normal immune system. They interfere with the production of useful antibodies, so people become much more prone to infections.
So it hits multiple systems: bones, blood, kidneys, immune system. That's a clear summary. Now, differential diagnosis. If myeloma is suspected, what else is on the list?
Good question. Because the M protein is key, you have to consider other things that cause an M protein.
Yeah.
Top of the list is MGUS.
Which we covered the protein is there, but crucially, no myeloma symptoms or organ damage.
Exactly. The memory chip here is useful. MGUS, maybe growing, usually stable. It emphasizes the potential, but often slow nature.
Nice. What else?
AL amyloidosis, where
Okay.
the bits of the light chains deposit in organs. Solitary plasmacytoma, just a single tumor of plasma cells, not widespread marrow disease.
Okay.
And some types of B-cell non-Hodgkin's lymphoma, particularly Waldenstrom's macroglobulinemia, can produce an M protein, usually IgM type. Even chronic lymphocytic leukemia, CLL, sometimes can.
So finding the M protein is just the first clue. You need the whole picture.
Absolutely. It's the M protein plus the clinical signs of damage the cellular features will come to that really points towards active myeloma needing treatment.
Okay, makes sense. Let's look at the epidemiology then. How common is this?
In the UK, it's the 18th most common cancer overall. Counts for about 2% of all cancer cases.
And primarily affects older people.
Yes, mainly people over 60. The average age at diagnosis is actually around 72, and slightly more common in men.
And in terms of blood cancers,
It's the second most common hematological malignancy, right after non-Hodgkin lymphoma.
and prognosis-wise.
It accounts for about 2% of cancer deaths. Incidence is roughly 4.5 to 6 cases per 100,000 people per year. Mortality around 4 per 100,000. And again, that higher incidence in Afro-Caribbean populations is notable.
So significant, especially in older adults and within blood cancers. Let's move to clinical features. How does it actually show up in patients?
Okay, this is where the CRAB mnemonic is really helpful, CRAB. It flags the big four. Hypercalcaemia, high calcium levels in the blood, renal dysfunction, kidney problems,
A4
anemia, low red blood cell count,
and B4.
bone pain or bone lesions.
Okay, CRAB, let's unpack those. Bone pain, where and what kind?
Often in the back, ribs, or hips. It can be quite persistent. And because the bones are weakened by those sciatic lesions,
They can break easily.
exactly, pathological fractures, breaks occurring with minimal or no trauma.
Okay. And anemia the A in CRAB, why does that happen again?
The myeloma cells crowd the bone marrow, squeezing out the normal red blood cell production.
And patients feel.
Tired, weak, maybe short of breath.
Yeah.
Fatigue is a really common symptom. The anemia is usually normocytic, normal chromic, normal size, normal color cells, just fewer of them.
Got it. Our renal dysfunction. We touched on the causes: calcium, the paraproteins.
Yes, high calcium can damage kidneys directly, and the light chains can cause myeloma-cast nephropathy, blocking the tubules. Kidney function decline is a serious issue.
And C, hypercalcaemia. High calcium, what symptoms does that cause?
It can cause things like excessive thirst, constipation, nausea, sometimes confusion or altered mental state if it's severe. The classic phrase is bones, stones, abdominal groans, and psychiatric overtones.
Right. So CRAB is key. Are there other signs we should know about?
Definitely. Because the marrow is affected, Platelet counts can drop thrombocytopenia, leading to easy bruising or bleeding.
Hmm.
General symptoms like night sweats, unexplained weight loss can occur too.
Mhm.
And because the immune system is weak, recurrent infections are very common.
Mhm.
Pneumonia is a classic example.
Okay. Anything else?
Sometimes the spleen or liver might be enlarged. You might see signs of the paraprotein depositing in tissues like an enlarged tongue, macroglossia, or carpal tunnel syndrome. Cardiac arrhythmias can happen. And then there's hyperviscosity.
Ah, yes, the blood getting too thick.
Exactly. If the M protein level gets really high, it can thicken the blood, causing dizziness, confusion, blurred vision, headaches, even nosebleeds, epistaxis.
So it can present in many different ways. Really need to keep it in mind. Okay, so if a clinician suspects myeloma based on these features, what tests come next? Investigations.
Starts with blood tests, usually.
Mm-hmm.
A full blood count, FBC, checks for anemia, low platelets.
Uh-huh.
Urea and electrolytes, UNEs, are crucial for kidney function, looking for raised urea, creatinine, and especially for checking the calcium level. Raised calcium is a big flag.
And looking at the blood under the microscope.
The peripheral blood film might show rouleau formation, red cells stacking up like coins. It's not specific to myeloma, but suggests high protein levels.
And the key tests for the abnormal protein itself.
Serum protein electrophoresis, SPEP. This separates blood proteins by charge and size. In myeloma, you often see a sharp spike in one region, the M spike or M band, showing a large amount of that single monoclonal immunoglobulin, usually IgG or IgA.
Okay.
And urine protein electrophoresis, UPEP, looks for those Benz-Jones proteins, the monoclonal light chains, in the urine.
And to be absolutely sure about the plasma cells in the marrow.
You need a bone marrow biopsy, an aspirin and tryphin biopsy. Finding 10% or more clonal plasma cells is a major diagnostic criterion.
Clonal meaning they all come from the same original rogue cell.
Exactly. And imaging is vital too, to look for those bone lesions.
What kind of imaging?
Nowadays, whole-body MRI or a low-dose whole-body CT scan is preferred over old-fashioned skeletal surveys. They're much more sensitive for picking up lesions. The classic raindrop skull on X-ray is sometimes mentioned, but MRI CT are standard now.
So if a GP suspects it, what initial tests might they order?
They likely start with FBC, maybe ESR or plasma viscosity, which can be raised. Definitely UNEs, including calcium and creatinine, albumin, maybe uric acid. And crucially, serum protein electrophoresis and the serum-free light chain assay. Plus, urine electrophoresis for Benz-Jones protein, maybe quantitative immunoglobulins too, and an X-ray if there's specific bone pain.
Important point in the notes. These protein tests can sometimes be negative, right? Even myeloma.
Yes, in about 5% of cases, called non-secretory myeloma, the cells don't release the protein into the blood or urine in detectable amounts.
So you can't rely only on those tests.
Correct. That's why NICE guidelines stress using both serum protein electrophoresis and the serum-free light chain assay together, as the light chain assay can pick up cases missed by ASPEP alone. Serum immunofixation is then used to confirm the type of protein. But even then, if clinical suspicion is high, negative tests don't completely rule it out.
Okay, so if initial tests are suggestive, what happens in secondary care with the hematologist?
You'll definitely do the bone marrow aspirate and tryphin biopsy, including flow cytometry to analyze the plasma cells properly, immunofixation of serum and urine to precisely type the M protein, comprehensive imaging, usually that whole-body MRI or low-dose CT.
And tests for prognosis, too.
Yes. SH analysis on the bone marrow cells looks for specific high-risk chromosomal abnormalities. Serum beta-2 microglobulin and albumin levels are measured. They're part of the staging system, and they'll quantify the amount of M protein accurately.
And all this information helps differentiate between MGUS, smoldering myeloma, and active symptomatic myeloma.
Precisely. MGUS and smoldering myeloma don't usually need immediate treatment, just careful monitoring, watch and wait. Symptomatic myeloma needs treatment promptly to prevent further organ damage.
What defines symptomatic myeloma according to the International Myeloma Working Group criteria?
You need either 10% or more clonal plasma cells in the bone marrow, or a proven plasmacytoma, plus at least one myeloma-defining event. That could be one of the CRAB criteria: calcium 0.25 millimole above upper limit, renal insufficiency with creatinine 177 mole, anemia with HB 100 GL or 20 GL below lower limit, or bone lesions, one or more osteolytic lesion on imaging. Or it could be other biomarkers of malignancy, like having 60% or more plasma cells in the marrow, a very abnormal serum-free light chain ratio, or specific findings on MRI.
Okay, so CRAB features or these other high-risk markers, and smoldering myeloma.
Smoldering has the M protein, O3-GDL, or 10-60% marrow plasma cells, but none of those myeloma-defining events. No CREB, no high-risk biomarker.
And MGUS is even less, and protein 3 GDL, marrow plasma cells 10%, and no related organ damage.
Exactly. The thresholds and the presence or absence of damage are key.
What about things like CT for small lesions or MRI for spinal cord issues?
CT is good for picking up smaller bone lesions missed on X-ray. MRI is excellent for looking at bone marrow involvement, soft tissue masses of myeloma cells, and critically, for detecting spinal cord compression, which is an emergency.
And the chromosome analysis, FISH.
Crucial for prognosis. Certain abnormalities like deletion 17p or translocation T414 indicate higher risk disease that might need more intensive treatment. Beta-2 microglobulin is also key for staging and prognosis. Serum viscosity might be checked if symptoms suggest it.
Okay, so summarizing investigations. It's a multi-pronged approach. Lab tests for proteins and organ function, imaging for bones and complications, and bone marrow biopsy for the definitive diagnosis and genetic risk assessment. Things like anemia, high calcium, rouleau, raised viscosity are all red flags pointing towards further investigation.
That's a great summary. So, once symptomatic myeloma is diagnosed, we need to talk management. What's the plan?
Right, treatment has become quite complex, which is good news in many ways. It involves combinations, usually chemotherapy, definitely, but also newer approaches like immunotherapy, targeted drugs that hit specific pathways in the myeloma cells.
And stem cell transplantation for some patients.
Exactly, autologous stem cell transplant, using the patient's own stem cells. But the choice really depends on the individual, their age, general fitness, the specific risk level of their myeloma.
So for someone newly diagnosed, symptomatic, and potentially eligible for a transplant, typically younger, fitter patients, what's the first step? The induction therapy.
Often a combination like bortezomib, which is a proteasome inhibitor, along with dexamethasone, a steroid. Sometimes other drugs are added too. The goal is to knock the myeloma back significantly before the transplant.
And for those who aren't transplant candidates, maybe older or less fit patients.
The approach might be different. Maybe combinations involving an alkylating agent like melphalan, perhaps with thalidomide or lenalidomide, and dexamethasone, again, aiming to get the disease under control.
Okay. And after induction, maybe a transplant. What then? Is there ongoing treatment?
Sometimes. Maintenance therapy isn't standard for everyone, especially older patients, but for younger adults who've had a good response to transplant, maintenance with a drug like lenalidomide is often used to try and keep the myeloma in remission for longer.
And monitoring is key, presumably.
Absolutely. Regular blood tests, checking those M protein levels with electrophoresis, sometimes repeat imaging or bone marrow checks. Myeloma often goes into remission, but unfortunately relapse is common.
So what happens when it relapses or if it doesn't respond well initially, refractory disease? Treatment depends on many factors than what they had before. How long the remission lasted, patient fitness. There are lots of options now. Different combinations involving drugs like lenalidomide, bortezomib again, pomalidomide, newer antibody therapies like daratumumab or lotuzumab. Sometimes a second transplant might even be considered. It's very individualized.
And alongside treating the myeloma itself, managing symptoms is crucial, right? Especially pain.
Hugely important. Pain management is key to quality of life. Starts with simple analgesics like paracetamol, maybe opioids. Drugs like amitriptyline or gabapentin can help with nerve pain, which myeloma or its treatment can cause. Steroids like dexamethasone help with bone pain too.
And other options.
Radiotherapy can be very effective for localized bone pain from a specific lesion. Chemotherapy itself reduces pain by shrinking the myeloma. Sometimes surgery is needed for fractures or spinal stabilization.
So the overall goals are controlling the disease, prolonging life, but also really focusing on maintaining quality of life. Needs a whole team, doesn't it?
Definitely. Hematologists, oncologists, specialist nurses, pain team, physios, a multidisciplinary approach is essential. And constant monitoring and adjusting the plan.
Okay, that brings us to prognosis. What's the outlook these days? You mentioned improvements.
Yes, thankfully the outlook has improved dramatically. With modern therapies, survival has significantly increased, quadrupled in the UK over the last 50 years, according to the notes.
That's incredible progress, but it still varies a lot.
It does. Some people can live well for many years, maybe more than 8 years, but for others, particularly those with high-risk genetic features, survival might be much shorter, perhaps closer to 2 years. It's a wide spectrum.
The notes mention a 10-year survival in England around 29%, similar for men and women.
Yes, gender doesn't seem to be a major prognostic factor in itself.
Hmm.
What is important is the stage at diagnosis, using systems like the ISS or the revised ISS, which incorporate beta-2, microglobulin, albumin, LDH, and those high-risk genetic markers from PMJ.
So specific gene changes really impact outcome.
They do. Things like deletion 17p are associated with poorer outcomes. Age is also a factor independently, as is how well the myeloma responds to the initial treatment.
So generally, a younger, fitter patient who responds well to chemo and transplant might expect what sort of survival?
Maybe around 7 years or potentially longer in some cases, but again, it's highly variable. And presenting as an emergency, perhaps with severe kidney failure or spinal cord compression, tends to be linked with a worse prognosis. Here's where it gets really interesting. Thinking about those improvements, where might we be heading?
Before we look ahead, let's cover the complications. The notes say over 80% have bone lesions, which must cause problems.
Absolutely. The complications often stem from the CRAB features themselves or the underlying disease process. So, hypercalcaemia, renal impairment, anemia, and infections due to the weakened immune system are major ones.
And spinal cord compression.
Yes, a neurological emergency if a vertebral lesion collapses or grows and presses on the cord. Fractures are common due to the weakened bones. Hyperviscosity syndrome we mentioned, peripheral neuropathy, nerve damage, sometimes from the disease, sometimes from treatment. Bleeding problems. And rarely, AL amyloidosis can develop secondary to myeloma.
That's quite a list. How are these managed or prevented?
Managing bone health is paramount. Bisphosphonates like zoledronic acid are standard care. They strengthen bone, reduce fracture risk, and lower calcium.
What about actual fractures?
Non-spinal fractures might need surgery or radiotherapy. Spinal issues need careful management. Bisphosphonates, pain control, sometimes surgery or cement injection procedures like vertebroplasty to stabilize vertebrae.
And preventing infections.
Vaccinations are important. Flu, pneumococcal. Sometimes prophylactic antibiotics or antivirals are used, especially during certain treatments. 4-V immunoglobulin replacement might be needed if antibody levels are very low and infections are recurrent.
Managing neuropathy, thrombosis risk, fatigue.
Neuropathy might require adjusting the myeloma treatment, plus specific pain meds. Thromboprophylaxis, blood thinners, might be used, as some myeloma drugs increase clot risk. Fatigue linked to anemia might be helped by erythropoietin injections to boost red cells.
So what does this all mean?
It means managing myeloma isn't just about chemotherapy. It's about comprehensive supportive care alongside anticipating, preventing, and treating these complications vigorously to maintain function and quality of life.
Right. So wrapping up, multiple myeloma. It's a complex plasma cell cancer. Lots of different ways it can show up. Requires very tailored management, tackling both the cancer and its complications. Early diagnosis, comprehensive care. That's the key.
Absolutely. And don't forget CRAB, hypercalcemia, renal dysfunction, anemia, bone pain. It's such a useful anchor for remembering the core clinical issues.
Definitely worth locking that one away. If you're revising, do revisit the notes. Maybe listen back to this. It's a lot to take in. Now, thinking about those treatment advances, here's a thought. What will the long-term landscape look like for people diagnosed with myeloma in, say, the next 10 or 20 years? It feels like an area with real potential for further change.
It certainly does. Lots of ongoing research.
Food for thought. Thanks for joining us for this deep dive.
Until next time.
For more in-depth revision resources and practice questions, be sure to check out pastthemsSRA.com. And for even more free learning materials, visit freemsSRA.com.